Namaste to everyone, and a very warm welcome to this live session of 25 most important questions on this YouTube channel. And I hope you all are doing great. I hope all of you are studying nicely. You are positive, you are focused, and you are right on your toes. Before we start this session, beta, I would just like to remind you that these 22 days, what we are left with, you can do a miracle in these 22 days. Believe in yourself. Have positivity inside you. If you are able to work very hard in these 22 days, you can score really big. ये जो 22 दिन है ना बेटा, इस 22 दिन में बहुत अच्छे से खेलना है. जितने भी अपने नोट्स वर्कबुक में हैं, उनकी एक एक लाइन कोशिश करके 22 दिन ऐसे रगड़ डालो, बिल्कुल जैसे चूरन चटनी बना के, काढ़ा बना के बिल्कुल उसको पी जाओ. ठीक है, ये 22 दिन हमारी जिंदगी के लिए बहुत इंपॉर्टेंट दिन है और हम कोई भी ऐसी चीज नहीं करेंगे जो हमें इस 22 दिन में मेहनत से वंचित करे. और हम 30 जुलाई को करिश्मा करके दिखाएंगे और अपनी जीत का परचम लहराएंगे और अपने माँ बाप की आंखों में वो खुशी के आंसू देखेंगे. राइट बेटा? ग्रेट. सो let's straight on start with I was just going through some of the comments mentioned here regarding Glasgow Coma scale. Voting was going on. Yes beta, as you can see, the very first question for you is related to the Glasgow Coma score, right? So that is because in the various examinations like NEET, PG and FMGE, they have been asking this number of times, except in the last conducted FMGE exam. So they gave a question on 5th of March in the NEET PG as well. Another small thing which I would like to share, a lot of turbulences would be going on regarding the next exam or something like that. But now we know that 2023, we are not having this next exam, right? So let us be at peace. Fine. Now let's read. Let's first see how we have to solve these MCQs. So the first mistake here is the options A, B, C, D. Rather than A, B, C, D, they are B, C, D, E, right? Okay, fine. Now let's take a look at this question. This looks to be a small question only, not a very big question. So patient after head trauma presented in the emergency. On examination, he was not able to open his eyes on painful stimulus. He was not able to open his eyes on painful stimulus. What does this mean, beta? We'll see. What does this mean? Okay. He shows extension motor movement and was able to make incomprehensible sounds. According to categorization by Glasgow Coma score, grading of severity of injury in this patient will be. So wonderful, beta. So what I have tried to do is I have just tried to mix the Glasgow Coma scale and the grading of severity of injury. So first of all, we should know what is Glasgow Coma scale quickly. If we take a look at the Glasgow Coma scale, so my dear lovely friends, 3 components: the electronic voting machine, eye, verbal and motor. Spontaneous 4, to sound or voice 3, pressure, pain 2, no eye movement 1, verbal, conscious, oriented to time, place and person 5, confused 4, inappropriate words 3, incomprehensible sounds 2, and no sound at all 1. Motor movements, if he is obeying all the commands 6, localize 5, withdraws or normal flexion movement, that is 4, abnormal flexion 3, extension 2, and no movement at all 1. So if we see maximum E 4, V 5, M 6. So total maximum GCS is 4 plus 5 plus 6, that is 15. Total minimum possible GCS E1, V1, M1, that is total minimum GCS is 3. So GCS ranges from 3 to 15. And now you can categorize into mild, moderate and severe. 13 to 15 is mild, 9 to 12 is moderate, and 8 or less than 8 is severe. So Chalti ke 9 se 12 is moderate. Right. Perfect. Now let us just try to see what is the GCS in this particular patient. Beta, he was not able to open his eyes on painful stimulus. So if he is able to open his eyes on painful stimulus, it is E2. But if he is not able to open his eyes on painful stimulus, this becomes E1. right? Even on painful stimulus, he is not able to open his eyes. Great. Now, the verbal movements, he is making only incomprehensible sounds. So that is V2. And he is making extension movement, right? Okay. So that is again M2. So if you calculate it, the total GCS possible will be 5. And if you look at the grading of severity of injury, you all know beta, mild would be 13 to 15, moderate would be 9 to 12, and severe would be 8 or less than 8. So here it is 5. So the correct answer for this will be severe, right? Fine. Let me just see. Yes. Very good, beta. Saurabh, you got it right. Santosh, majority of you got it right, beta. Yes, Dr. Atropine, the answer is E. Perfect. Great. That's really good. Perfect, beta. So one thing which we know, that we cannot skip this Glasgow Coma scale at any cost. Great. So now let's move on to another question, beta. One question which we know they are commonly asking nowadays is something related to shock, right? So here the question is, yes, everybody, non-hemorrhagic causes of hypovolemic shock include all except. Now, let us just try to understand what the examiner is asking, right? Yes. So I'll just wait for your answers, beta. While you are answering, I would just like to tell you, beta, shock simply means inadequate organ perfusion and tissue oxygenation. That means when the tissues are not getting proper oxygen supply. There may be so many reasons for this, right? Okay. Right. Great. So many of you have answered D. Some of you are answering B, A. Right. Great. Wow. Wonderful. Very good. So you are able to understand. Mahi, Ruchi, it's moving really fast. So I'm not able to take the names, beta. Akash, Divya, yes. Right. Anil, Santosh. Swapnil has answered C. We'll just see what is the correct answer. Rishabh has answered A. Okay. So first thing, beta, if we try to take a look that what actually is shock before we answer this question, beta. Okay. Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration with insufficient delivery of oxygen and glucose, and the cells switch from aerobic to anaerobic metabolism. The different types of shock, beta, we see the classification, the latest updated classification for shock says the commonest shock what we experience is hemorrhagic or hypovolemic shock. Then there is cardiogenic, obstructive, distributive, and endocrine shock. Basically, obstructive shock is just like a neurogenic shock when there is a traffic jam in the veins and the venous return is not able to come to the heart properly. And the distributive shock you can correlate with the septic shock, wherein if there is party going on in some or the other organ, that organ will receive more amount of blood supply. So there will be compromise in oxygenation to various other areas. So there is distribution of the fluid, right? So these are the different types of shock, beta. And now if we try to focus on what is this hypovolemic shock, as the name implies, beta, hypovolemia simply means when the circulating blood volume decreases, right? So if the circulating blood volume decreases, that is hypovolemia. What we generally know in trauma situations, the circulating blood volume जो शरीर में बेटा खून की पाइपलाइन बिछी हुई है, वो पाइपलाइन फट जाती है ना, ट्रॉमा हुआ कहीं का भी. If the pipeline of blood inside a body that ruptures, that burst, may be anywhere in the body, we know that the circulating volume will decrease, right? So this is the hemorrhagic cause of hypovolemia. In this particular question, he is asking non-hemorrhagic causes of hypovolemia. That means he doesn't want to talk anything related to trauma situation where there is bleeding going on, okay? Now, what can be the non-hemorrhagic causes? Okay, so non-hemorrhagic causes can be if there is poor fluid intake, maybe related to dehydration, or there is excessive fluid loss, whether it is due to vomiting, diarrhea, or urinary loss, or when there is fluid loss in the third spaces, like what we see in bowel obstruction or pancreatitis. In pancreatitis, beta, acute pancreatitis, we all understand there is lots and 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 lots of fluid loss, so that the patient presents in hypovolemic shock, right? This is an acute pancreatitis, what we see. So basically the examiner is trying to know what are the non-hemorrhagic causes of hypovolemic shock. Okay, so non-hemorrhagic causes. He's not talking anything about trauma, but he's talking about reduced circulating volume. So if the person is dehydrated, the circulating volume will go down. Yes. If vomiting is there, again the circulating volume will go down. Diarrhea is there, the circulating volume will go down. In cardiac tamponade, yes, there will be blood accumulation in the pericardial cavity, right, which is going to put pressure on the heart, and the heart will not be able to contract properly, and that will be causing the cardiogenic shock. And you know, beta, there is one triad. Yes, who will answer this? What is the triad seen in cardiac tamponade? Yes, beta, I'll be waiting. Okay, so right. What is the triad seen in cardiac tamponade? Yes, beta. Pawan Kumar is the first one to answer that triad, and that is Beck's triad. Yes, Pawan, can you tell me what is that Beck's triad? Anirudh, yes, you got it right. Tactile, yes. Wonderful. So Beck's is basically hypotension, raised JVP, and muffled heart sounds, right, in cardiac tamponade. So beta, cardiac tamponade is actually going to cause a cardiogenic shock. Plus in cardiac tamponade, there is hemorrhage. There is bleeding in the pericardial cavity, right? So we can exclude this cardiac tamponade as the non-hemorrhagic cause of hypovolemic shock. That is why many of you got it right. And beta, let me applaud all of you who got it right. And those who were not able to get it right, yes, we were able to learn that what is actually shock, what are the different categories of shock, classification of shock, and what is this hypovolemic shock, which can be hemorrhagic or non-hemorrhagic shock, right? So the correct answer, yes, it is cardiac tamponade. Wonderful. Muffled heart sounds, hypertension, and distended neck veins. That's right, Dr. Vidya. Perfect. That's really good. Wonderful, beta. Right. So now let's move to another question. Just to remind you, beta, the great Indian poet Shri Harivansh Rai Bachchan साहब, आज अपने ख्वाब को मैं सच बनाना चाहता हूँ, दूर की इस कल्पना के पास जाना चाहता हूँ. You have got everything to do it, beta. आपके अंदर हर वो चीज़ है, हर वो जज्बा है करिश्मा करने का. बस बॉयज दिन रगड़ देना अपने आप को और दिखा देना अपनी ताकत इस पूरी दुनिया को. Right. Okay, so now another question, Vijay. Which of the following is not seen in the non-contrast CT scan image below? Generally in the image-based questions, beta, what we try to see is we look at the image first, and then we look at the options, and then we go with the question. Okay, right. So very good. So majority of you, Mahesh, Sidhu, Dopamine, Garima, Ganesh. Okay, so majority of you are answering this as EDH, right? So those who were not able to look at the options, they are yes, they are answering this as EDH. Okay, so now let me just look at the options. I have seen the image. Let me look at the options first. In this occipital bone fracture, extradural hematoma, midline shift, and subdural hematoma. These are the various options. So till the time I have not read the question, I've just looked at the image. We know in extradural hematoma, it is hyperdense biconvex. So we can see this white density here, and we can make out that yes, this is the convexity, which is more important for us, and the outer convexity, yes, this is also there. So this is the biconvex extradural hematoma, right? Hyperdense. But let us just quickly read what he's asking in the question. So beta, this has been included so that you do not commit the silly mistake, because we all know that in the exams, these are hot image based questions which you have been seeing number of times at so many platforms as well. And just you look at the image, look at the option, and you are in a hurry to mark the answer as extradural hematoma. But please be careful, in the question the examiner has written something else. Which of the following is not seen in the non-contrast CT scan image below? Oh, great. That means, yes, idli, you're saying, beta, idli is extradural. So you are able to see the extradural hematoma here. That means if I try to outline this, this is the extradural hematoma. Now let me see out of the other three options. So this is not the correct answer, beta. Out of the other three options, what is not seen? Midline shift, he is asking. So beta, can you appreciate there is a midline shift? We all can understand that yes, this should have been the midline story, right? So this should have been the midline story. So are we able to see any shift? Yes. Here what I'm seeing, this is the midline shift, right? So I'm able to see the midline shift in this CT scan. That means this is also not be my answer. I'm seeing the midline shift. Now, am I able to see occipital bone fracture or subdural hematoma? This is what I have to make out. Let me try to see in the occipital region, beta. So are you able to see any fracture line in this area? No, I'm not able to see any fracture line in this area. Okay, so this thing what we are seeing, the bright white shadow, this is the bone, but I am not able to see any fracture in the occipital region in this. Now what he's saying, the subdural hematoma. Let me look at the image carefully and let me try to figure out whether I am able to see the subdural hematoma in this or not. Oh yes, if you carefully see here, you can see a hyperdense shadow which is seen in this particular area, right? So if I try to focus myself in this area, then yes, this particular thing what I am seeing here, I can consider that this is a concavo-convex area. So this can be the subdural hematoma what I am seeing here. Once again, beta, you can carefully take a look and you can see that concavity in this particular area. Right? So this concavity, this is suggestive of that subdural hematoma, right? That means in the given options, I'm able to see the extradural hematoma, midline shift, and also the subdural hematoma, but I'm not able to see the occipital bone fracture. So my answer for this will be occipital bone fracture. Wonderful, beta. Great. So many of you got it right, beta. Yes, Lavlesh, Harshal, Snow Leopard, Praveen, yes, beta. Great. Radhesham, good. Fine, beta. So just be careful because this is a hot image based question asked so frequently. So there was a little twist, just reminding you of the various images. The convex hyperdense, this is what we see in extradural hematoma. This what we are able to see the bilateral convexities here. So right. So in this area, I can see the bilateral convexities. So this will be a bilateral frontal extradural hematoma. Right. And here what I'm able to see, this is the subdural hematoma. Right. So this surface is what we'll focus on, the concavity part. Right. So this will be concavo-convex, the banana, what you were saying. Great. Right, beta. So now moving further ahead. Oh, this looks to be a long question, beta. And if it's a long question, the art of solving the lengthy questions is first read the last line of the question. So I'm going to read the last line first, then look at the options. So I'll be looking at the options and then I'll be going with the body of the question. Right. The last line of the question is, which of the following is least appropriate about the basic resuscitation? Exam में क्या ध्यान रखना है बेटा? What we have to remember in the exam, that we have to be careful that we will not commit the silly mistakes. What he's trying to ask is least appropriate about the basic resuscitation. तो हमें क्या करना है, हमें रूल आउट करना है कि बेसिक रिससिटेशन में हम क्या नहीं करते, मतलब हमें ये पता होना चाहिए कि बेसिक रिससिटेशन में what we are supposed to do in basic resuscitation, and we have to just rule out one thing. Okay, right. Now let's take a look what we don't do in the basic resuscitation. Have a look at the options. Gray colored IV cannulas were put and crystalloid infusion started in the emergency. So we are putting the gray colored IV cannulas. Okay. If the patient is coming to us in shock, then if you remember the color coding of the IV cannulas, beta, the orange, gray, green, pink, blue, yellow, violet. है ना? So orange, gray, green, pink, blue, yellow, violet. This is 14, 16, 18, 20, 22, 24 and 26. In shock patients, the 14, 16 gauge cannulas, they have got wide bore. We prefer using these cannulas. So gray colored cannulas, yes, we are using in pumping large volumes of fluid in a short period of time. Do we assess the Glasgow Coma scale in the basic resuscitation? Yes, because Glasgow Coma scale, what we know about is any trauma situation or any situation where there is reduced circulating volume. Look at me on the screen, beta. Any situation where there is reduced circulating volume. जब भी pipeline में volume कम होगी, what will happen to the pressure in the pipeline? Pipeline में pressure कम होगा. So if the pressure in the pipeline, that is if the blood pressure decreases, what will happen to oxygen supply to the brain? The oxygen supply to the brain will decrease. There may be any situation causing reduction in circulating blood volume. Any situation. चाहे फीमर टूटी हो, चाहे dehydration, vomiting वाली कहानी हो, right? If the circulating blood volume is going down, the blood pressure will be going down, oxygen supply to the brain will decrease, and then the brain will be showing hypoxic damage status. Duration of hypoxia to the brain is directly proportional to irreversible brain damage, and we don't want to happen to the patient. You are going to be great doctors of this country, beta. आपके पास बहुत बड़ी चीज है, बहुत बड़ी जिम्मेदारी है, जिंदगियां बचानी है. You have to save as many lives as possible, है ना बेटा? तो if you have to save the lives, you have to be careful कि boss, I cannot reduce oxygen supply to the brain at any cost, right? So that is why a quick GCS assessment is done, so that we come to know what is happening to the oxygen supply, right? Endotracheal intubation, yes, we know the ABCD story, airway, breathing, circulation and disability story. So yes, endotracheal intubation is a part of basic resuscitation. Okay, now CECT, quick CECT was done, which demonstrated splenic rupture. Now beta, if by chance we look at the question, if the basic resuscitation is being done, that means patient would be hemodynamically unstable. और अगर पेशेंट अनस्टेबल है तो इतना वक्त नहीं अपने पास कि अपन पेशेंट को सीटी कमरे में भेजें और वहां सीटी उसका किया जाए और वो सीटी कमरे से ही बोर्डिंग हो जाए. Right? We don't want to waste precious time for a hemodynamically unstable patient by sending the patient for a CT scan. So there is no role of CT scan in a hemodynamically unstable patient who will be requiring basic resuscitation, right? So looking at these four options, I have not read the question yet, but yes, I can make out ki boss, putting wide bore cannulas, Glasgow Coma scale, endotracheal intubation, these are important as a part of basic resuscitation, but doing a CCT is not like that. Okay, so now let me read the question. Mr. Y met with a road traffic accident and is suspected of having multiple injuries over the chest and abdomen. He was having brownish discoloration over the mastoid. जल्दी से बताओ बेटा, what is this brownish discoloration over the mastoid? इसको क्या बोलते हैं अपन? Brownish discoloration over the mastoid. Yes. Very good, Love Pandey. Fast is done. That's right. This is Bettel sign, right? Brownish or yes. Yes, Bettel sign is correct. Yes, Vanna. Very good. Great. So, there was Bettel sign positive. There was CSF autouria, discharge of blood-tinged fluid from the right ear. He was having bruises over the left lower chest and the upper abdomen. His shock index was 1.5. So, beta, shock index क्या होता है? Shock index is a ratio of heart rate to systolic blood pressure. What we know is कि normal heart rate suppose अपन मानते हैं कि 70 to 80 या मान लो 72 है or systolic blood pressure is 120. So this ratio is much less than 1. It would be somewhere around 0.66 के आसपास होगा, है ना? So this is something which is normal. लेकिन any patient who is going into hypovolemia, where the circulating blood volume is going down, the heart will start pumping faster and faster, so the heart rate will increase. Heart rate may go up to 100 and systolic blood pressure would be falling down. So if the systolic BP is falling down, then this ratio becomes 1, right? Okay, and if the circulating blood volume further decreases, so the heart rate would be increasing, say 120, and the systolic BP would be going down to say 80. So now this ratio has become more than 1. So 1 or more than 1 means patient is hemodynamically unstable, right? Okay, so in a hemodynamically unstable patient following a road traffic accident, the basic resuscitation was going on, and the only investigation which we do in these scenarios is FAST, that is focus assessment by sonography in trauma. So it is not CECT, it is actually FAST, which could have been the right thing which would have been done. So we can rule out this answer, right? So the answer for this question is D. Great. Right. Another question. Now this is a image based question, right? Now beta, you have to try to identify what is this image, right? I'll remove myself from the screen. Just try to identify beta, what is this? Yes. This is effusion. That's really good. The pleural effusion. Pneumothorax. In pneumothorax, there would have been a hyperlucency rahil. है ना, पूरा काला दिखाई दे रहा था. The entire story would have been black. But here what we are able to see, if we carefully try to take a look, that we are able to see the costophrenic angles nicely on this side. But what is happening on this side? On this side, we are not able to see the costophrenic angle. We are not able to see this. There is a white haziness which is seen in this area. So this is some collection in this area, some liquid collection in this area, right? Okay. So this can be a hemothorax, pleural effusion. Yes. Yes. Very good. Very good. So all of you are able to make this out. So the art of solving image-based questions, beta, first we look at the image, then we look at the options, so that our mind focuses only on the available options. And the available options are ultrasound guided drainage of pleural collection. Yes, we can do that. Endotracheal intubation. Endotracheal intubation. Basically, just by looking at the X-ray, we know that it's a collection of fluid in the left pleural cavity. So we have to drain it. Let us see if there is anything in the question to suggest whether endotracheal intubation has to be done or not. Tracheostomy, intermittent positive pressure ventilation. These are the methods by which we are trying to secure the airway, right? Intermittent positive pressure ventilation is one of the methods which can be done in the treatment for flail chest, right? Yes, very good, Siddharth. So the left CP angle is not there, okay? Fine. Now let us just try to see. A patient suffered an accident and presented with mild discomfort in the chest. Oh, so I'll just try to highlight this. There was a mild discomfort in the chest with breathing difficulty. Okay. On X-ray, there was blunting of the costophrenic angle on the left side with missing lucency of the lung in the left lower base. So which of the following will be helpful in the management of this patient? So if there is only mild difficulty in breathing, why to go for an endotracheal intubation or a tracheostomy? And intermittent positive pressure ventilation is something which is required maybe in cases of flail chest to force the flail segment to remain away from the lungs to avoid injuries, right? So looking at all the available options, it's a clear-cut case, simple case of pleural effusion, and we can simply do a ultrasound guided drainage of the pleural collection. Very good, beta. Let me have a big round of applause for all of you, beta. Piyush, Mahita, Snow Leopard, Atul, Moti, Hari, everyone, Naved, right? So you all have got it right. Santosh, wonderful. Piyush, well done. Great. Atul, Deepak, Veer, right. So now let's, this was just to give you an idea, beta, that on 30th of July, we might be having few questions related to pneumothorax or maybe hemothorax or maybe hemopneumothorax or maybe tension pneumothorax. Like in this particular X-ray, what we can see, on this side, we are able to see the lung to be normal, but on this side, we are able to see more blackness. So, plus we are not able to see the bronchovascular markings in this more black area. That means this is a case of lung collapse with collection of air in this area. So this is the left pneumothorax, basically. If we take a look at this particular X-ray, let me just try to remove myself so that you can have a nice look at this X-ray. Yes. So in this particular X-ray, beta, you are able to see that on the right side, there is a huge amount of blackness seen, and we are not able to see any bronchovascular markings on the right side. So we are not able to see the bronchovascular markings here, right? Okay, so this also should be a case of massive collection of air, and plus I am able to see some mediastinal shift as well. So this can be a case of tension pneumothorax as well, right? This was just a picture to demonstrate that what is tension pneumothorax. When huge amount of air gets collected on one side, it is not only going to cause ipsilateral lung collapse, but because of huge amount of pressure, it is going to put pressure on the mediastinum. There will be mediastinal shift in tension pneumothorax, which will put pressure on the other lung as well. And we all know, beta, that God has given us two air balloons. भगवान ने अपने को दो हवा के गुब्बारे दिए. अगर एक गुब्बारा फुस हुआ, if one lung is collapsed, we still have got the other lung for ventilation. So patient may have only mild dyspnea type of story, but if any situation where both the lungs are under pressure and if both the lungs are getting collapsed, अगर दोनों गुब्बारे दब गए हैं, then patient will not be able to breathe properly. He will be in a dire emergency situation of respiratory distress, and that will require immediate wide bore needle insertion to drain the tension pneumothorax, right? Okay. Another image just to emphasize that this is also one of the image where you can see there is a blunting of the costophrenic angle, there is white haziness on this side. So again, there is fluid collection in the right pleural cavity here. Okay. So let's try to see if we can do something related to audio. Let us see if this becomes better a bit. Right. Okay. Another question, beta. This also looks to be a long question. So let us try to read the last line of the question first, and then let us read the options, and then we'll be going to the stem of the question. Right. So here he says, which of the following is false? So first of all, I'll make an impression he is asking something related to false. Regarding atherosclerotic chronic arterial obstructive disease of the right superficial femoral artery. Okay, so he's asking something related to traffic jam in the superficial femoral artery, right? Okay. Just a moment. I'll just try to ask the team if they can make it better. Just a second. Yeah. So we'll just try if the echo has gone. Right. So basically, false regarding atherosclerotic chronic arterial obstructive disease of the right superficial femoral artery. Okay. Very good. Thank you, beta. Thank you so much. Thank you for your replies. Great. Now it's fine, I guess, right? Yeah. Okay, so atherosclerotic chronic arterial obstructive disease, beta. He is asking about chronic arterial obstructive disease. The commonest cause of chronic gradual arterial obstruction is atherosclerosis, and he's asking what is false. Okay, so let me just analyze what are the options. Pain is usually felt in the calf muscles. Okay, so many of you are answering as D, and I saw one answer as B also. Let me see. Okay, muscle group affected is below the level of arterial disease, right? Distance at which pain occurs gradually increases with passing day unless treated. Okay. Distance at which pain occurs decreases if walking uphill or increasing the speed of walking. Okay. So majority of you, every one of you have answered it as D. Let me Sagar has answered it as C. Himanshu is also asking why not C. So we'll just try to read this question first before we jump on to analysis of this question. A 65-year-old man presented to the OPD with complaints of pain in the right lower limb on walking a certain distance. He noticed that the pain subsides on resting. Okay. And he's asking chronic arterial obstructive disease. Right. So basically, if we try to analyze or understand that what is happening in this situation, suppose I try to create that abdominal aorta, then this is bifurcating into common iliacs dividing into internal and external iliacs, external iliac continuing down as the femoral artery, right? So suppose this is the femoral artery here, then this will become the popliteal artery, anterior tibial, posterior tibial, and the dorsal pedis artery. So basically, we'll be focusing in this area as a femoral artery. Abhi, he is saying chronic arterial obstruction. So gradual arterial obstruction, atheromatous plaque has started developing here in the femoral artery. Obviously, the distal blood supply is going to go down. That means initially what happens in these chronic diseases, initially, ideally what should happen if there is a traffic jam in this area, the most distal part, that is the foot, that should face the problem, right? So patient should experience pain here. But before the patient experiences pain here, what happens? When this person is walking, then the most bulky muscular area in the lower limb is the calf area. And when he is walking, the demand by the calf muscles increases drastically. And because of the traffic jam here, desired amount of blood supply is not able to reach into the calf muscle. And if desired amount of blood is not going into the calf muscle, then patients start presenting with pain in the calf on walking. So the story of gradual arterial obstruction starts with intermittent claudication, which is calf pain on walking. If the disease progresses further, then the patient will start experiencing rest pain in the foot. And if the story progresses further, then the patient may develop pregangrene and gangrene of the foot. So these are the different stages of gradual arterial obstruction. Right, Bitta? Ab, what we have to see here, we have to focus on this calf pain story. This calf pain will definitely be below the level of arterial obstruction. That is very clear. This intermittent claudication of this calf pain is experienced on walking only. It is not present on rest. It is not present on taking the first step. Right? Now, if I try to see that how this intermittent claudication will progress. So, beta, initially what would be happening in this patient? In the early stages, initially, suppose जब कहानी शुरू हुई है ना, at the starting, suppose patient was able to walk for 800 meters and after that he started experiencing pain in the calf, right? As the disease will progress, then what will happen? Then the patient may start experiencing the calf pain, say at 600 meters. As the disease progress, he will start experiencing this intermittent claudication at 400 meters. So बेटा एक चीज ध्यान रखना, what the examiner has done in this question is he has tried to emphasize कि boss what will happen to the distance of claudication. अगर डिजीज बढ़ती है तो claudication distance means the distance at which the pain starts in the calf. तो ये बताओ बेटा कि जब डिजीज बढ़ेगी तो क्लॉडिकेशन डिस्टेंस बढ़ेगा कि कम होगा. पहले 800 मीटर पे दर्द होता था, फिर 600 पे होने लगा, फिर 400 पे होने लगा. इनिशियली पेशेंट वाज एक्सपीरियंसिंग पेन एट 800 meters, then gradually is experiencing at 600 meters, then at 400 meters, then maybe at 200 meters. That means the distance at which the pain is occurring is actually decreasing, है ना. और अगर मान लो if we ask this patient कि बॉस हिल पे चढ़ जाओ, है ना, या वेट लेके चढ़ जाओ, तो द डिस्टेंस विच ही विल बी एबल टू वॉक. सपोज बेटा सीधी सड़क थी, अगर सीधी सड़क पे चल रहा था एंड देन सपोज ही वाज एबल टू वॉक फॉर 600 मीटर, लेकिन अगर अपने सड़क को इंक्लाइन कर दिया, अब ही हैज टू वॉक लाइक दिस, तो डेफिनेटली ही विल नॉट बी एबल टू वॉक फॉर 600 मीटर्स ना. तो सपोज ही इज एबल टू वॉक ओनली 400 मीटर्स. तो अगर इफ ही इज वॉकिंग ऑन अ हिल और ही इज वॉकिंग विद द वेट्स ऑन हिमसेल्फ, राइट, then the distance which he is able to walk will decrease. ठीक है बेटा, तो decrease. Very good, wonderful. So now everyone, Daya, Ritesh, Mystery, Sana, Deepak, so claudication distance will decrease. अतुल धीरे धीरे इसको रेस्ट पेन भी होने लगेगा. Very good बेटा, wonderful, great. So now let us try to see. Pain is usually felt in the calf muscles, that is right. Muscle group affected is below the level of arterial disease, that is right. Distance at which the pain occurs gradually increases with passing day unless treated. Increase नहीं होगा बेटा, decrease होता है ना. तो ये wrong statement है and he is asking false. So this is a wrong statement. Distance at which pain occurs gradually will decrease. Distance at which pain occurs decreases if walking uphill or increase the speed of walking, right? तो that means ये बात तो सही है. पहले अगर सीधी रोड पे चलता तो 600 मीटर चल लेता, लेकिन अगर रोड को इंक्लाइन कर दिया, हिल पे चढ़ रहा है, तो 600 मीटर पे नहीं 400 मीटर पे ही दर्द होने लगेगा, है ना. तो ये स्टेटमेंट तो सही है. Distance at which pain occurs decreases if he is walking uphill or increasing the speed of walking. That means the false statement here is this C. Right. Okay. Right. So now the correct answer is C. Very good. So investigation of choice is color Doppler. Yes. Got it. Great. Moral of the story: without any motion or movement, there is no life. 22 days, we can do miracles. We have to just keep moving. We have to have that positivity. We have to have that consistency inside us. क्योंकि बेटा बहुत सारे लोग हैं जो आपकी उस खुशी का इंतजार कर रहे हैं. There are so many people who are waiting to see those great happiness in your eyes. Right. Right, beta. Now, another hot question, beta. For the last few exams, the examiner has been focusing on this coronary artery bypass grafting. So I thought to include this in our session. Which of the following graft will provide the best long-term patency rates in coronary artery bypass grafting amongst the given options? Before we proceed, I would just like to update you regarding what is mentioned in the latest edition of Standard Textbook of Surgery, Bailey and Love, the 28th edition. How to select the conduit for coronary artery bypass grafting. We have got two options. We can use the venous grafts, we can use the arterial grafts. In the venous grafts, it is the long saphenous vein which is most commonly used venous conduit, as it is very easy to harvest. It provides a very good length for anastomosis and it is very easy to handle. Right? But the only drawback is it has got a limited patency rate. The patency rate is only 50 to 60% at 10 years. However, nowadays, lot of trials are going on, and those trials have suggested that if we give some medicines along with this venous graft, we can increase the patency rates as well. If by chance long saphenous vein is not available, suppose the long saphenous vein is varicose or something, and we have to harvest a venous graft, then the alternative venous conduit is a short saphenous vein beta. तो लॉन्ग सेफेनस वेन मोस्ट कॉमनली हम यूज कर सकते हैं वीनस ग्राफ्ट अगर हमें लेना है. इफ लॉन्ग सेफेनस इज नॉट देयर, देन शॉर्ट सेफेनस वेन वी कैन ऑल्सो टेक द cephalic vein. If we focus on the arterial grafts beta, then the left internal memory artery, that is the lima or the internal thoracic artery, has become the conduit of choice now for left anterior descending artery grafting, and it has got a 10-year patency rate of more than 95%. That is why this MCQ has become a hot MCQ, that now the preferred graft for a long-term patency is the lima, left internal memory artery. If we have to take an alternative artery for this CABG, then radial artery graft also undergone has a recent revival, and it has an excellent patency rates at 1 and 5 years. Right. So basically, best long-term patency rates, this is a previous year question, and the answer is left internal memory artery, which all of you have got it right. But just to remind you that it is the left internal memory artery or the internal thoracic artery, or we can use the radial artery in the vein grafts, the long saphenous vein. If not available, then short saphenous vein and the cephalic vein. These can be used. Right. Oh, good. Now this looks to be an easy question, simple single line type of question. Which of the following is not helpful in the management of Raynaud's disease? Okay, so let us just see that. देखो बेटा, जैसे ही सी लगाया ना अपन ने, हाँ वो लीमा आंसर इज करेक्ट. राइट. अब देखते हैं बेटा, लेट अस सी व्हाट आर यू गोइंग टू आंसर फॉर दिस. Yes, Preeti is the first one to answer this. Wonderful. Kavya, very good. Garima, Tokir, Shubhangi, Radhesham, Narendra, Mahita. Wow, great. Anurag, Himanshu, Mittu, Aman. Everyone has answered it D. Great. That means very good, beta. All of you, a big round of applause for all of you, beta, that you are not going to miss out on this, right? Great. Perfect. Now, let me just remind you some important points about Raynaud's disease, because I feel that the examiner may ask a question from Raynaud's in this upcoming 30th of July exam. So just to remind you about Raynaud's, this is idiopathic, commonly seen in young females. It affects hands more than the feet. There is abnormal sensitivity in the arteriolar response to cold, and there is a characteristic Raynaud's phenomena, that is a sequence of color changes, that is from white, blue, and red. This is often accompanied by pain, and the treatment is protection from cold, avoid pulp and nail bed infections, calcium channel blockers and nitrates like nifedipine can be used. Electrically heated gloves can be used in the treatment of this Raynaud's disease to avoid the cold exposure. What is Raynaud's syndrome? Raynaud's syndrome is a peripheral arterial manifestation of a collagen disease such as SLE or rheumatoid arthritis. The clinical features are as of Raynaud's, but they may be more aggressive. Raynaud's syndrome may also follow the use of vibrating tools, and this is vibration white finger, and the treatment is almost the same. The calcium channel blockers, the nitrates, we can even use the steroids, and we have to remove the cause. And those who are having this vibrating white finger, then obviously we should ask them to avoid vibrating tools. Right. Very good. So if we look at the options here, in the treatment for Raynaud's, we use the electrically heated gloves. We ask the patient to avoid the pulp and nail bed infection. We can use nifedipine, but we don't use dopamine. Obviously, it will have opposite effect. Right. Great. As we know, beta, that success is no accident. It is hard work, perseverance, learning, studying, sacrifice, and most of all, love of what you are doing. So keep loving your studies. Just 22 days to go and you will definitely do great. Fine. Now this is another hot question, beta. I feel that in the coming exam we are going to get one or the other question from the mastitis or the breast abscess story, right? So this is a image based question here where we can see some drainage tube, and now let us try to see the options. So there was a drainage tube which we saw in the breast. Now the options are better cosmetic result than incision and drainage, shorter duration of antibiotics needed as compared to incision and drainage, daycare procedure, does not hamper breastfeeding. Wow, Ramesh, thank you very much, beta. God bless you. Wonderful. May God bless you like anything, and may you keep on treating as many patients as possible. It's really lovely to see our students doing great. Right. Okay, beta. So now let us just take a look at the last line of the question. Reason for preferring the treatment method as shown in the image include all except. Okay, so again there is all except. That means we have to again try to see what is wrong. So if I try to read the question, a 28-year-old postpartum lactating female presented with redness swelling of the left breast. She is having high-grade fever for 2 days and pus culture suggested presence of Staph aureus. Ultrasound showed 4 into 4 centimeter hypoechoic collection in the left breast. A reason for preferring the treatment method as shown in the image include all except. Now here what we are seeing, this is a percutaneous drainage and this is not an incision and drainage. So my dear lovely friends, all of you who are watching this session, all the Mistians as well, nowadays there is a change in the guidelines in the treatment for breast abscess, wherein even if there is a good amount of liquid collection inside the breast, then we prefer by draining it with the help of ultrasound guidance. We can just aspirate the pus and we can leave a catheter, a suction drain or a vacuum drain within the abscess cavity. And the reasons are, yes, if we are not making an incision to drain the abscess, it will offer a better cosmetic result. That's true. Shorter duration of antibiotics needed as compared to incision and drainage. Now, let me just see this option again later on. Daycare procedure, ultrasound guided aspiration and putting a catheter in the abscess cavity. Yes, it's a daycare procedure. Making an incision to drain the breast abscess, that can also be a daycare procedure. But yes, many a times we need to keep the patient admitted because the operation is done under general anesthesia. So maybe for 1 day or 2 days we admit the patient. Does not hamper breastfeeding. Yes, if we are making an incision to drain the abscess, it may hamper breastfeeding, but just doing a vacuum drainage will not hamper that. Now, this option, shorter duration of antibiotics needed. If we are making incision to drain the abscess, then suppose I say that this is the breast and there was an abscess inside the breast, say here. If I make an incision to drain this abscess, suppose I make an incision like this, a radial incision, then huge amount of pus has already been removed. So the duration of antibiotics required in this patient will be less. But if I compare this, for example, if I say there is an abscess, say like this, and now what I'm doing is I'm just making a small cut here and then putting a catheter in this. So if I'm just putting a catheter in this to drain the abscess, definitely this will still be having more amount of pus. So the duration of antibiotics required in this particular case will be more as compared to when we are making an incision and drainage to drain the abscess, right? So yes, here the antibiotic duration is approximately 14 days. When we are doing ultrasound guided catheter drainage, the antibiotics have to be given for 14 days. And quickly, if we just try to take a look, that most common cause of breast abscess is Staph aureus. Abscesses, they are more commonly seen during the lactation, and in the lactation phase, they are more common in the first month and then at the time of weaning. in the first month after the first childbirth. This is because of inexperience or inappropriate or inadequate breastfeeding. The chances of breast abscess are more in the first month, especially after the first childbirth. And then the chances of breast abscess are more at the time of weaning, and this is because of engorgement of the breast and trauma to the nipple by the baby's teeth. However, the commonest reason for breast abscess is Staph aureus entering into the mother's breast through the cracks in the nipple, right? Now, generally, if it's a classical breast abscess, this presents as a fluctuating lump. If it is a deep-seated abscess, then fluctuation may be absent. And the classical signs of acute inflammation, rubor tumor, Calor dolor will be there. It may also be associated with enlarged axillary lymph nodes, which may be tender. Ultrasound can reveal cellulitis type of changes in the early stage, which is seen as increased echogenicity. In late stages, when good amount of liquid collection is there, ultrasound will show liquefaction necrosis, and pus will be seen as a hypoechoic collection with floating debris in that abscess inside the breast, and this will change with changing posture, right? Now, the recommended guidelines, everyone, antibiotics are targeted against Staph aureus, and they are cloxacillin, flucloxacillin, erythromycin. Breastfeeding is allowed from both the breast and should be encouraged 2 hourly, followed by emptying of the breast. Breast support garments, cold compressions, analgesia, any pus on ultrasound is aspirated for culture and sensitivity. Please note, according to the latest edition of Bailey and Love, contrary to the practice of incision and drainage in a breast abscess, ultrasound-guided drainage gives an excellent cosmetic result, does not hamper breastfeeding, and can be done as a daycare procedure with a high rate of success. Incision and drainage may result in a non-healing milk fistula. In abscesses which are more than 3 centimeters in diameter or those containing more than 30 ml of pus, on ultrasound, a vacuum suction catheter is inserted under ultrasound guidance to drain the pus. Right. Great, beta. So this was a deliberate inclusion from my side because I feel that mastitis breast abscess area, this is going to be hot area for the MCQs for 30th of July. Right. Fine. Another question. Now this also looks to be an image-based question. This looks to be ultrasound image. And on the ultrasound, what I'm able to see is a nicely smooth margins swelling. Right. Now let me look at the options, what he's trying to say. Breast mouse, phyloid tumor, giant fibroadenoma, and invasive ductal carcinoma. Okay. That means all the 4 options what he has given here, they are related to some pathologies in the breast. Breast mouse क्या होता है बेटा? Breast mouse is fibroadenoma. Phyloid tumor क्या था बेटा? Serocystic disease of Brody, right? Giant fibroadenoma is more than 5 centimeters. And invasive ductal carcinoma. अच्छा बेटा, looking at this image, what I know is कि जो fibroadenomas होते हैं ना, they are having they are benign lesions, so they are having smooth margins. जैसा कि हमें यहाँ पे दिख रहा है, they are smooth margins. If it would have been cancer, then the margins would have been irregular, right? So एक चीज तो ये हुई. Phyloid tumor is something which is generally seen after 40 years of age due to stromal hyperplasia, and in this it actually involves almost the entire breast. So it's a diffuse, so it is not such a small story usually. It's a diffuse variegated bosselated appearance of the breast is seen in phyloid tumor, right? So now what I'm left with is, just by looking at the ultrasound we are trying to see this, breast mouse and giant fibroadenoma. Let us see what he's asking. Which one of the following is the most likely diagnosis? So beta, most likely diagnosis, right? Okay, fine. Most likely diagnosis में, let us read the question also to understand. 24-year-old. So if it is 24-year-old, the commonest cause of tumor inside the breast in a young female, especially less than 25 years, it is fibroadenoma. Right? So 24-year-old female, freely mobile, well circumscribed lump of 3 centimeter in size in her right breast. It is painless with no discharge from the nipple. Ultrasound is shown below, which is the most likely diagnosis. Right, beta. Very good, Himanshu. Wonderful. So basically, it is fibroadenoma and it is not giant fibroadenoma. अगर giant fibroadenoma होता बेटा तो यहाँ पे size क्या लिखा होता? What would have been the size mentioned if the answer would have been a giant fibroadenoma? Yes, everybody got it right, beta. Very good. Every one of you have got it right. Divya, Narendra, Hari, Sirat, Anas, Nitesh, Umar, Yesh, Daya, Lucky, Anil. Very good. So it is a breast mouse. So it's a fibroadenoma. यहाँ पे size क्या था? Very good knowledge, Kumar. That's right. Vipul, wonderful. So the size would have been more than 5 centimeters if the answer would have been giant fibroadenoma, right? So he has not written fibroadenoma in the option, but he has written breast mouse in the options, right? So breast mouse is correct. Wonderful, beta. We know, beta, that you have really done lots and lots and lots and lots of hard work during this journey. We know that we are almost there now, just 22 days to go. Since you have worked really hard earlier as well, try that particular hard work should not go in vain, and make your today even better than yesterday so that your yesterday becomes jealous of you, right? Let's try our best to do it. Great. Wonderful. So this looks to be a wonderful question. Simple single liner question. Most common nerve injured during submandibular gland surgery. Yes, beta. Let's see what's the answer. Wonderful. So Karishma, Preeti, Mukesh, Ramesh, every one of you have marked the answer A. So once again, I would like to applaud all of you, beta. Just to remind you that this would be a simple single liner question, 30th of July, and we should know sublingual gland surgeries, that is ranula surgery. The most common structure damage is submandibular duct, and most common nerve damage in sublingual gland surgery is lingual nerve. For submandibular gland surgeries, the nerves which are injured in the sequence, marginal mandibular, lingual, and the hypoglossal. And for parotid surgeries, the nerve injured is the facial nerve. Important question, right? Great, wonderful. Now let's move into the systemic surgery area, where we'll be talking about pediatric, adult, and oncosurgery questions. So anyone who can identify what is this? Yes, Piyush. Yes, beta. Anyone? What can be this pathology, beta? This is a midline neck swelling, right? So this is a midline neck swelling. Perfect. So this is a thyroglossal cyst. That's absolutely correct. Now let's look at the options. May represent the persistence of second branchial cleft. No, second branchial cleft is what? Branchial cyst. Branchial cyst and branchial fistula story. It does not move with protrusion of tongue. Thyroglossal cyst move with protrusion of tongue. Thyroglossal cyst characteristic feature is it also moves with protrusion of tongue, also moves with deglutition, right? MRI guided biopsy is used to confirm a cyst? No, generally we just do ultrasound and we can confirm this cyst. So MRI guided biopsy is not needed. Now cyst may become infected and rupture onto the skin of the neck, presenting as a discharging sinus. Yes, thyroglossal cyst, the complications are thyroglossal sinus. Rarely there can be thyroglossal fistula, and a cancer can develop in these thyroglossal cysts. Anybody, which cancer develop in thyroglossal cyst? Yes, so again, everyone has got it right. Very good. Great. Papillary thyroid cancer actually develops in this thyroglossal cyst. Right, beta. Let me just read the last line of the question. In fact, there is no last line. This is this continuous question. Which of the following is true about a pathology associated with persistence of thyroglossal tract and is found anywhere in or adjacent to the midline from the tongue base to the thyroid isthmus as shown? Right. Very good, beta. Papillary, that's perfect. Absolutely correct. If we quickly revise this, thyroglossal cyst is persistence of thyroglossal tract. There is accumulation of secretions, most often in midline, except in the region of thyroid cartilage. It may be situated just adjacent to the midline. More commonly seen in children. Most common site is beneath the hyoid bone. It consists of cholesterol crystals like branchial cyst and hydrocele fluid. It moves with deglutition. It also moves with protrusion of tongue. Now, this is going to be a hot area for your 30th of July, right? Fine. So here in the images also we can see that how the thyroglossal cyst is moving with the protrusion of tongue. Okay. The complications which can develop, there can be infection, abscess, and this can rupture resulting in thyroglossal sinus and rarely a thyroglossal fistula as well. Papillary thyroid cancer can develop, and as all of you were telling, that cyst trunks operation is done where we not only excise the cyst but we excise the entire thyroglossal tract, including the central portion of the hyoid bone right up to the tongue base, right? Just to remind you another thing, चलते रहो अपनी मंजिल के पथ पर, चलते चलते या तो मंजिल मिल जाएगी या चलना सीख जाओगे. Basically, you are very close to your destination, right? इस समय सब कुछ दुख रहा होगा, बट हिम्मत नहीं हारना बेटा. अपने को लड़ना है, अपने को ग्राइंड करना है, राइट? उस दर्द के साथ आगे बढ़ना है. ठीक है बेटा, दिमाग को शांत रखना है जितना हो सके. नींद अच्छे से लेनी है. वी हैव टू स्लीप वेल एटलीस्ट 6 hours क्योंकि वी हैव टू हैव अ गुड आउटपुट द नेक्स्ट डे ऑल्सो, राइट? ओके, चलिए. नाउ अनदर क्वेश्चन बेटा. दिस इज अ स्मॉल क्वेश्चन. विच ऑफ द फॉलोइंग इज करेक्ट about infantile idiopathic hypertrophic pyloric stenosis? Okay. Thank you, Nausheen beta. Thank you, Piyush. May God bless you. अभी अपने को क्या बताना है बेटा? What is correct about idiopathic hypertrophic pyloric stenosis? Correct बताना है. Okay. So hypertrophic pyloric stenosis को एक बार देख लेते हैं. What is this? There is hypertrophy of the circular muscle fibers. Usually firstborn male child is affected. The incidence is 2 to 3 per 1,000 live births. It presents during 3rd week of life. However, it can present between 2nd to 6th week. Generally, there is a olive lump in the epigastrium of the right hypochondrium, and this lump is because of thick pyloric muscle. If we give a test feed to the baby, we can see vigorous peristaltic movements from left to right side. There is projectile non-bilious vomiting, and because what is going to happen in traffic jam of the pylorus, whatever is there inside the stomach, that is going to come out. And we all know that inside the stomach we have got huge amount of acid. Acid is HCl. So there is huge loss of this acid. Acid loss will cause metabolic alkalosis. Chloride loss will cause hypochloremia. When there is metabolic alkalosis inside the body, the kidneys will try to compensate by excreting alkaline urine. Initially, the urine can be alkaline, but if the baby is persistently vomiting for 2, 3, 4 days, baby will also be getting dehydrated, and because dehydration becomes more important, the body will try to conserve water by stimulation of ADH aldosterone type of mechanisms. So there will be reabsorption of sodium and water from the kidney tubules. When sodium is getting reabsorbed, potassium and H ions will be excreted in urine. Potassium is going in urine, that is kaliuresis, which will cause hypokalemia. And H ions going in urine will cause the urine to be acidic. Because there was metabolic alkalosis, ideally the urine should have been alkaline. But just to conserve water, there is excretion of H ions. So the urine has become acidic. This is paradoxical aciduria. Ultrasound is the gold standard investigation which can show us The thickened pyloric musculature more than 3 to 4 millimeter and lengthening of the pyloric canal more than 16 to 17 millimeter, right? When this baby comes in the emergency, the first and foremost thing what we are supposed to do is we have to stabilize the patient, rehydration, electrolyte correction. That is the first step. Initially, we can try doing a pneumatic balloon dilatation, but the best treatment would be Ramstead seromyotomy, right? Okay. Single bubble, very good, Sana. Single bubble, pylorus, double duodenal, triple jejunal, multiple central small intestine, multiple peripheral large intestine. Right. So now let's take a look at this question, beta, and we have to tell what is correct. So there is projectile bilious vomiting. Bilious, no. In pyloric stenosis, it will be non-bilious. But in duodenal atresia or any traffic jam which is distal to the opening of bile duct in the duodenum. Any traffic jam which is distal to the opening of bile duct in the duodenum, the vomiting will be having bile. So duodenal atresia will be having bilious vomiting, but pyloric stenosis will be having non-bilious vomiting. Okay, there is hypertrophy of circular muscle fiber. This statement is right, but it is not bilious, it is non-bilious vomiting. Loss of gastric acid causes hyperchloremic hypokalemic alkalosis. ओ तो बेटा यहाँ पे क्या ध्यान रखना था, ये हाइपर लिखा है बेटा, और अभी अपन ने क्या देखा था, व्हाट वी सॉ, देयर विल बी हाइपो, सो देयर विल बी हाइपोक्लोरीमिया, नॉट हाइपरक्लोरीमिया. So we have to be careful, right? So this is also wrong. Visible peristalsis from left to right in the epigastrium after test feed? Yes, we can see this. And diagnosis is best made on plain X-ray? No, it is not plain X-ray, it is ultrasound. Right, beta? So what is the correct answer? As all of you have said, the answer is C. Very good. Great. एक बार और बेटा आप सब लोगों के लिए जोरदार तालियां. बस लगे रहना बेटा, छोड़ना नहीं, बिल्कुल बस फोड़ना है, वो वक्त आ रहा है, बस 22 दिन है ना, हिम्मत नहीं हारना, लड़ना है. राइट. Okay. Now, which of the following is an MRI of polycystic kidney disease? Okay, so he's asking which is an MRI of polycystic kidney disease. Now, let me first see what is this. Yes, beta. What is this? I'm just waiting for your response, beta. ये क्या है बेटा? This is polycystic kidney disease or horseshoe kidney or this is a CT scan. Yes. So I hope we all can make out, beta. You are able to see this bone is appearing white. So this should be a CT. And here on both the sides, what we can notice is we can notice multiple cysts in both the kidneys, right? So there are multiple cysts seen in both the kidneys. So this is a CT of polycystic kidney disease. Now let us see this. Okay. Again, we can see the two kidneys and we can see there are lots and lots of cystic shadows seen in the kidney, and here the bone is appearing black. So this can be an MRI of polycystic kidney disease. Let's have a look at other options as well. Very good. Okay. Now, beta, can you tell me what is this? This is CT or MR, and what is the pathology in this? This is a PYQ, beta, right? This image has been asked earlier, right? No, it is not putty, beta. Yes, this is MRI. Very good. Shubhangi, wonderful. This is MRI, and this is horseshoe kidney. Very good. Perfect, beta. So you'll be able to identify that this is MRI of horseshoe kidney, right? Okay. Now, what is this? This is again, if there are two kidneys here, and here we can see there are multiple cysts seen inside the liver as well, inside the kidneys as well. Okay. Now this is a CT or MR. So this is also a case of polycystic kidney disease plus polycystic liver disease as well. Right. So because the bones are appearing white, so this should be a CT scan. Right. So if now we look at all the 4 images, we can make out that this is a CT scan, this is a CT scan. He is asking MRI. So these are gone. We are left with these two. These two are MRIs. And in these two, this is the MRI for polycystic kidney disease and this is the MRI for horseshoe kidney disease. Right. Perfect. So the correct answer for this will be B. Great. Wonderful. Right, beta. Now this question has been deliberately included now, because we are seeing these type of questions in the recent years. So we should be prepared. And I pretty well understand that all of you are fully equipped now to come out firing with these type of questions, right? Okay. Another question, beta. 10 months old male baby presented with empty hemiscrotum. Empty hemiscrotum मतलब एक तरफ का scrotum empty है. One side scrotum is empty. On examination, the left testis was found in the left inguinal canal, while the right testis was in the bottom of the scrotum. Correct about the diagnosis in this baby. Bilateral normal testis, left ectopic, left vanishing, left undescended. Okay. Now let's see. Divya, I would just like to remind you, beta. So, some of you are answering it as B, some of you are answering it as D, right? Okay. Now, majority of you are answering it as D. Great. Okay, beta. So, just wanted to remind you, beta, that during intrauterine life, we know that the testes follow a definite path of descent, right? And if the testes get arrested anywhere in the normal path of descent, if the testes are arrested anywhere in this normal path, this is undescended. If the testes deviate from the normal path and come to lie somewhere else, that is ectopic. There is one term called as retractile. In retractile, the testis is already descended in the scrotum. But if we try to elicit the cremasteric reflex, then the testes ascend upwards and they may go into the inguinal canal. But for those testes, it is possible for us to gently bring the testes down to the bottom of the scrotum. They are retractile, they are not pathological testes. Vanishing testis is a term, beta, where in intrauterine life, the testis has started developing, but before birth, they disappear. So that is what is vanishing testis, right? Okay, fine. If I repeat this in Hindi, beta, अगर टेस्टिस अपने नॉर्मल रास्ते में कहीं पे अटक जाती है तो अनडिसेंडेड, भटक जाती है तो एक्टोपिक, अगर उचक जाती है तो रिट्रैक्टाइल, अटक गई अनडिसेंडेड, भटक गई एक्टोपिक, उचक गई रिट्रैक्टाइल, राइट? ठीक है बेटा. वैनिशिंग बनी तो थी लेकिन बर्थ से पहले ही गायब हो गई, राइट? फाइन. अभी undescended testes can be found at the deep inguinal ring, but most commonly they are found in the inguinal canal. They can even be found at the superficial inguinal ring or the top of the scrotum. Ectopic testis most commonly is found in the superficial inguinal pouch or the Dennis Brown pouch. They can be found in the femoral triangle, in the perineum, or maybe at the root of penis, right? So, and the treatment for this would be orchidopexy, which is ideally done at 6 months and can be done up to 12 months or maybe 18 months also. So beta, if the left testis is in the left inguinal canal, right testis is in the bottom of the scrotum. That means right testis is normal, but left testis is undescended. So if you look at these different options, as you all said, the correct answer will be left undescended testis. Right. Right. Thank you, beta. Thank you all in one. उम्र थका नहीं सकती, ठोकरें गिरा नहीं सकती, अगर जिद हो जीतने की तो हार भी हरा नहीं सकती। अब्दुल कलाम साहब ने बहुत प्यारी लाइनें लिखी हैं बेटा, राइट। अगर जिद हो जीतने की तो हार भी हरा नहीं सकती, इसको ध्यान रखना। आपने जिद ठानी हुई है बेटा कि दुनिया की कोई भी ताकत आपको 30 जुलाई को हरा नहीं पाएगी। उसके लिए करना क्या है आपने को, बस ये जो 22 दिन है ये पूरी तरह से रगड़ डालो अपनी वर्कबुक के साथ। एक एक सेकंड बहुत कीमती है, छोड़ना नहीं, लगे रहना बस। दुनिया आपके कदमों में होगी। अगर 22 दिन पूरी शिद्दत से, पूरी ईमानदारी से हम मेहनत कर गए तो कोई नहीं हरा पाएगा आपको, राइट। चलिए बेटा देखते हैं व्हाट इज दिस, विच आर द फॉलोइंग इज बेस्ट सुटेबल डायग्नोसिस फॉर द इमेज शोन। सो इफ यू लुक एट दिस इमेज बेटा, क्या लग रहा है ये? वेरी गुड। सो सिंपल क्वेश्चन, corkscrew appearance, yes, corkscrew appearance is seen in diffuse esophageal spasm. So looking at the image and looking at the options, ecclesia cardia में bird beak pencil tip, red tail भी मिल सकता है, absence of gastric air bubble मिलता है, diffuse esophageal spasm में corkscrew esophagus मिलता है, Xanthus में we see a outpouching in the upper esophagus, बिल्कुल it's a pharyngeal pouch, तो pharyngeal portion, posterior pharyngeal wall through the inferior constrictor Killian's dehiscence it protrudes outward. Tertiary bronchus is not the correct answer for this. These are few images what we know. This what you are seeing, this is the classical pencil tip, right, or the bird beak appearance in ecclesia cardia story here. Here what you are seeing, there is a rat tail type of appearance, and this image what you are seeing beta, this is a diverticula hanging, right? So this would be a Xanthus diverticula, right? Great. So basically the answer for this question will be diffuse esophageal spasm, right? Oh, so after binge drinking, a young male presented with hematemesis to the emergency in an unstable condition, most likely cause. अब यहाँ पे बेटा binge drinking वाली जो कहानी है, we know that this area is also something where MCQ people keep on asking lots and lots of questions. So binge drinking means heavy drinking at one point of time. एक बार में ज़्यादा पी लिए, right? तो उससे क्या होगा? Because of this, the stomach will be full, the stomach will be irritated, and the stomach muscles will contract forcefully. So there will be forceful vomiting. And अब ध्यान से सुनना बेटा, if there is forceful vomiting, so there can be two things. If I try to mark them here, suppose I say कि boss this is the esophagus and this is the stomach, and there is forceful vomiting because of fullness inside the stomach. तो अभी if there is a tear at the esophagogastric junction or the GE junction, if there is a tear here, this is called as a Mallory-Weiss tear, and this tear causes bleeding. If due to forceful vomiting, the esophagus ruptures so that the gastric contents leak into the mediastinum, this is Bohr-Harvey syndrome or barotrauma, right? I repeat this in Hindi also beta. अगर किसी ने एक बार में ज़्यादा पी ली है बिंज ड्रिंकिंग, तो स्टमक भर जाएगा, स्टमक की म्यूकोसा इरिटेट होगी, मसल्स इरिटेट होंगी और स्टमक जोर जोर से कॉन्ट्रैक्ट करेगा. एंड बिकॉज ऑफ दिस फोर्सफुल कॉन्ट्रैक्शन, उसकी वजह से जो प्रेशर जनरेट होगा, उस प्रेशर की वजह से बेटा जो गैस्ट्रोइसोफेजियल जंक्शन है वहाँ की म्यूकोसा टियर हो सकती है. और अगर सिर्फ म्यूकोसा टियर हो रही है तो ब्लीड करेगी तो खून की उल्टी आएगी, हेमाटेमेसिस. दिस इज मैलोरी-वीस टियर. लेकिन इफ फोर्सफुल वॉमिटिंग की वजह से अगर ज़्यादा प्रेशर ईसोफेगस में आया, खासकर बुजुर्गों में, तो ये बूढ़ा ईसोफेगस उस प्रेशर को बर्दाश्त नहीं कर पाएगा और ईसोफेगस फट जाएगा. जब ये ईसोफेगस फटेगा तो जो भी सामान था वो सारा प्रेशर के साथ यहाँ मीडियास्टिनम में लीक करेगा और उससे सीवियर मीडियास्टिनाइटिस होगी, राइट? Another question which was asked recently was related to hematemesis and chronic alcoholic, chronic liver disease, portal hypertension, cirrhosis of liver. If he is saying chronic alcoholic, chronic liver disease, hematemesis, then the story is esophageal varices, right? So what I've tried to do is I've tried to sort it out for you, a comparison of Boerhaave, Mallory-Weiss and esophageal varices. Boerhaave, Mallory-Weiss both are associated with binge drinking. Esophageal varices, chronic alcoholic, chronic liver disease. Boerhaave in the esophagus, Mallory-Weiss at the G junction and the cardia of stomach. G junction, if G junction is not there, then the cardia of stomach. This is according to 28th edition of Bailey and Love, right? The latest edition. Esophageal varices, they are in the esophagus. Boerhaave will be transmural क्योंकि perforation है तो all layers will be involved. Mucosa, submucosa, muscle. Mallory-Weiss only mucosa is going to get involved. Esophageal varices, mucosa and submucosa is going to get involved. Boerhaave will present with chest pain, left-sided chest pain radiating to the left shoulder and to the left arm. Mallory-Weiss and esophageal varices will present with hematemesis. Thank you, Sirat Beta. Thank you so very much. Thank you for motivating me as well. Right. Very good, Beta. So please remember, if you get a question related to this, you have to follow this guideline. Life has two rules. Never quit and always remember rule number 1. Just want to remind you, Beta, at this stage when you're just 22 days away from your exam, many a times it is very natural to get a feeling inside कि मुझसे नहीं होगा. I may not be able to do it, right? Before saying no, say I'll try and then give it your best. ना नहीं करना बेटा. माना कि बहुत थक चुके हैं, बहुत रगड़ चुके हैं, हिम्मत टूट रही है, लेकिन टूटना नहीं है बेटा. ये 22 दिन हमारी जिंदगी बदल सकते हैं. These 22 days can change our life. So please remember that come what may, you cannot afford to quit. हारना नहीं है, लड़ना है. और हम लड़ेंगे कि कुछ भी हो जाए. हमारी मेहनत में कमी नहीं करेंगे. We'll keep on grinding. We'll work very, very hard and we will prove to the entire world what we are capable of. Right? So don't quit at all. Right, beta. Now let's see. Another question where a common clinical scenario is generally given by the examiners. So let us just have a look at the question, not a very lengthy question. A chronic alcoholic patient presented in the emergency with sudden onset of central upper abdominal pain radiating to the back. Central upper abdominal pain radiating to the back with anorexia, nausea and occasional vomiting, amylase raised, most likely diagnosis. I hope. Simple question. Yes. Right. So is it acute cholecystitis, pancreatitis, appendicitis or diverticulitis of colon? Just want to remind you, beta, that what is there inside us. If we carefully take a look at our abdomen story, we know that this area, the upper abdomen, here is the stomach duodenum area and just below this is the pancreas. The right hypochondrium area is the liver and gallbladder area, the left hypochondrium for the spleen, the lumbar region is for the kidneys, the right iliac fossa is for the appendix, the cecum areas, and the left iliac region is for the sigmoid colon. So if we just try to see these 4 pathologies, beta, if he's saying acute cholecystitis, then the story should have been in the right upper abdomen or the right hypochondrium. The acute cholecystitis pain also presents something like this: severe pain in the right hypochondrium radiating to the back to the inferior angle of right scapula and sometimes to the tip of right shoulder. Acute pancreatitis, we know it is a central upper abdominal pain which radiates to the back either from the right side or from the left side, and this pain is classically relieved on sitting and bending forwards. If acute pancreatitis patient tries to lie supine, then the acutely inflamed pancreas, the red hot pancreas, will be irritated and the patient will not be able to lie. Patient will have more pain if he or she is trying to lie supine. So acute pancreatitis pain is the central upper abdominal pain radiating to the back, which is aggravated in supine but relieved in sitting and bending forward position. Right? Okay. Acute appendicitis, classically there is a periumbilical pain which shift or migrate to the right iliac fossa, right? And diverticulosis of colon pain would be seen in the left iliac fossa. Just to remind some important points about acute pancreatitis, as you can see here, that acute pancreatitis pain, the pain will be relieved on sitting and bending forwards, right? Pain will be aggravated in supine position, right? Apart from this, in acute pancreatitis, especially in acute hemorrhagic pancreatitis beta, you can find two signs. If there is bleeding in the retroperitoneum, this can trickle and come anteriorly, which may cause bluish discoloration in the flanks. If it is the flanks, then it is a Gray Turner sign. But if this bluish discoloration is seen around the umbilicus, then this is a Cullen's sign, right? So again, these are hot areas for our MCQs. Right. Great. So looking at this particular question, the central upper abdomen pain radiating to the back with anorexia, nausea, occasional vomiting, the answer will be acute pancreatitis. Good. Now this is an image-based question, and we'll just try to identify if there is anything we can make out in this particular image. Yes. So if I try to see here, I can see some radiopaque shadow in this area. There's a white shadow in this area. And nothing else in this area except there are a lot of gas shadows, right? So probably the bowel preparation has not been done in this patient. And here I can see something. Let me just try to focus a little more. Yeah, some radiopacities, continuous radiopacities seen in this particular area. And this is taking almost the shape of a ureter. So there is a possibility of a right kidney stone, plus there are multiple stones in the right lower ureter as well. Okay. On the left side, the story looks to be fine. Okay. Now let me see what all options he has mentioned. Options are ESWL, that is extracorporeal shockwave lithotripsy, PCNL, that is percutaneous nephrolithotomy, URS, that is ureteroscopic retrieval of stone, and fluid therapy. Okay, fine. So now let me read the last line of the question first, and then let me read the question as a whole. In this patient, there is evidence of radiopaque shadow in the right kidney with street of stones in the right lower ureter. Oh, so street of stones. Now, what is a street of stones? Street of stones is a specific term which is actually given for Steen-Strass phenomena. Steen-Strass. That is, when we do ESWL, when we do a shockwave lithotripsy, the stone is broken into small fragments, and these fragments form a line in the ureter, which is called as a Steen-Strass. So probably ESWL has been done, because of which the stone, there would have been a bigger stone in this area, it would have been broken, and some part is inside the kidney, remaining part is inside the kidney, and fragments have aligned themselves in the ureter. Okay, so now let's read the question. What would have been the most likely treatment offered to this patient? Most likely treatment offered to this patient. So as we discussed, that after ESWL, there is a possibility that there is a street of stones or a Steen-Strass seen in the ureter, right? So looking at this, the answer should be ESWL, right, beta? So all of you have got it right. Great. Now, if I just try to remind you that how we treat the urinary stones, stones which are less than 5 millimeter in size, because the diameter of ureter and urethra is 6 to 8 millimeter. So any stone which is less than 5 millimeter in size can pass spontaneously in urine. So only fluid therapy is recommended, right? Fine. Wow. I just missed, I guess. Alpha surgeon. Thank you so much, beta. And that's really lovely to know that you are a surgeon now. Many congratulations to you, beta. Please do ping me on my WhatsApp. Great. Other treatment modalities for urinary stones. Treatment of choice for kidney upper middle ureteric stone is ESWL, lower ureteric stone is URS. For kidney stones which are more than 1.5 centimeter in size or the upper ureteric stones more than 1.5 centimeters, we do PCNL. For bladder stones, we are doing litholapexy. And what we are doing in ESWL beta, we are just firing the shock waves, which is totally a non-invasive procedure, except that we put a stent in the ureter before this procedure. So these shock waves break the stone into small fragments, and these small fragments can pass spontaneously in urine. Right. Muskan, we would be finishing in the next 20-25 minutes, I guess. We are almost at question number 20 now. दर्द गम डर जो भी है बस तेरे अंदर है, खुद के बनाए पिंजरे से निकल कर देख, तू भी एक सिकंदर है. अभी वी आर इन द मोड ऑफ प्रिपरेशन, तो इसलिए हम किसी से कुछ नहीं कहने वाले. हम सिर्फ अपनी मेहनत पे फोकस करने वाले हैं, क्योंकि हमें पता है कि जीत हमारी है, सिकंदर हम बनने वाले हैं. बस विश्वास रखना है और तहे दिल से 22 दिन लग के रगड़ देना है, फोड़ देना है एकदम. राइट. This is an image-based question wherein various incisions are being demonstrated here. So this is the incision which is made in the right subcostal region. This is the incision which is made in the midline. This is the left paramedian incision. This is the left transverse incision. This is a McBurney's incision or a gridiron incision. And this is a Fen and steel incision. So as far as surgery is concerned, beta, we know that this area is for liver gallbladder story. So maybe this incision, which is a coccus incision, also can be used for gallbladder operations. This is a midline laparotomy incision for exploratory laparotomies, whether it is related to trauma situation or related to perforation peritonitis type of stories, we can make this midline incision. Left paramedian for upper abdominal surgeries, especially when we are focusing mainly on the partial gastrectomies or maybe on the splenic areas, we can go ahead with that. The McBurney's or the gridiron incision is for appendicectomy, and this transverse smiling incision in the lower abdomen, the Fen and steel incision, is for bladder and uterine surgeries. Whether it is lower segment cesarean section or hysterectomy or urinary bladder surgery, we are going ahead with this. Now let us take a look at the options here. Option 1 says for cholecystectomy. Yes, 1 is for cholecystectomy. 3 is for perforation peritonitis. Yes, exploratory laparotomy. 4 is for appendicectomy. Yes. And 5 is for hernioplasty. No, this Fen and steel is for bladder and uterine surgeries. For hernia surgeries, what we are doing is we are making an incision in the inguinal region. So for hernia surgeries, the incision is somewhat like this. So this should have been the incision for hernia surgery, right? Not this. This is for bladder and uterus. So let's see, most likely he would have asked what is false. If we take a look at the question here, which of the following is incorrect? So what is incorrect? It is D. 5 is not for hernioplasty. Right, beta. Great. Which of the following is not used in the medical treatment of BPH? Okay. So medical treatment of BPH, what is not used? What we know about BPH is benign prostatic hyperplasia, which is very common problem after 60 years of age in males. More than 50% of patients suffer from BPH, which occurs in the transitional zone, causing enlargement of the median and lateral lobes. Normal weight of prostate is 20 grams, right? In this, because of enlargement of the prostate, there is compression of the prostatic urethra, and because of this, a traffic jam develops in the urethra. So the proximal people, they get dilated, and then the patient presents with various symptoms. If the patient has got only mild symptoms of BPH, then we can treat this patient with medicines. But if the patient is having severe symptoms, or there may be some complications of BPH, beta, complications can be, अगर यहाँ का रास्ता पूरा बंद हो गया बिट्टू, तो ऊपर क्या होगा? If this area is completely closed, so what will happen? the intravesical pressure will increase, there will be bilateral hydronephrosis, post-void residual volume will increase. If it is more than 100 ml, it will be significant. Because of stasis of urine in the bladder, party in the bladder, UTI, recurrent urinary tract infections, stone formation, diverticular formation, sometimes patient can even go in uremia. So all these will be the complications of BPH. And if patient is having complications, beta, then we cannot wait for the medicines to act, because medicines are going to take a longer time. So if there are severe symptoms or complications, then we have to do surgical intervention. And the gold standard treatment for severe symptoms or complications in BPH is a transurethral resection of prostate. What you can see here, this is a transurethral resection of the prostate, right? Okay. When we say medical treatment for mild symptoms of BPH, there are two types of medicines. One medicine which relaxes the prostatic urethra and improves the urine flow. That is selective alpha-1A blockers, tamsulosin, alfuzosin. Another medicine which can reduce the size of prostate, 5-alpha reductase inhibitor, finasteride, dutasteride. They can be used, right? Medical treatment of choice will be selective alpha-1A blockers, tamsulosin, alfuzosin, right? So let us just take a look. Which of the following is not used? Tamsulosin, alfuzosin can be used. Rosuvastatin and dutasteride. Okay. So simple question, beta. Which medicine we are not going to use? Rosuvastatin. That is a statin, lipid lowering agent, right? Fine. So very good. Yes. So the answer is C. Great. Fine. Another question, 17-year-old boy presented in the emergency with severe pain in the scrotum for the last 2 hours. On examination, the right testis is lying high in the scrotum, tender and cremasteric reflex is absent. Elevation of the scrotum does not relieve pain. Most likely diagnosis in this patient. Yes, beta. I'll wait for your answers for this question. Nausheen, Arun, every one of you have marked the answer as C. Once again, a big round of applause for all of you, beta. That means you are not going to make any silly mistake in these type of questions. Perfect. So the answer is testicular torsion. Varicocele, what we know is abnormal dilatation of pampiniform plexus of veins around the testis, most often on the left side in tall, thin males, bag of warm feel in varicocele. Hydrocele is abnormal collection of fluid around the testis. Most common cause is filariasis, transillumination positive. A version of sac or Jabouille's operation is the treatment of choice in adults, while herniatomy after 3 years is the treatment of choice for congenital hydrocele. Testicular torsion, it is simply a torsion of the testis. Most common cause is bell clapper deformity, where there is high investment of tunica vaginalis, and the testis is high lying. The cord gets thickened, the cremasteric reflex is absent, there may be redness, swelling of the scrotum. Prince test is negative, that is elevation of scrotum does not relieve pain here. Elevation of scrotum relieve pain in epididyma orchitis, so their Prince sign is positive. And we do not want to waste any time in this by getting any color Doppler or something. The best thing is immediate scrotal exploration. If the testes are viable, 100% of the testes can be saved if the patient presents within 6 hours. So if the testes are viable, do a derotation, fix the testis orchidopexy, and for whatever reason, say one testis has undergone torsion today, for the same reason the other testis can also undergo torsion later. We don't want that, so we fix the other testis also, contralateral orchidopexy. So if the testis is viable, derotation, orchidopexy and contralateral orchidopexy. But if patient has come to us after 24 hours, only 20% of the testis can be salvaged. So there is a chance that testis might have undergone gangrenous changes, and if it is like that, we cannot keep this testis. We have to do orchidectomy, and do not forget to do a contralateral orchidopexy. Right. Thank you, Meme Akash beta. Thank you for showing your gratitude. Thank you for showing your faith and trust. May just God give you all the courage and strength to keep pumping hard and keep achieving your dreams on a continuous basis. Thank you so much, beta. Thank you for such nice words. Right. Now, if we have a look at some oncosurgery questions, this can be an important question on 30th of July, beta. This is regarding kidney cancer, when to do a partial or when to do a radical nephrectomy or radio or chemotherapy story. So in this, if it's a long question, what would be the treatment in this patient, whether a partial or a radical or a radio or chemotherapy? Right. Very good. For this, we'll have to take a look at the question. What we know before we read this question, let us see what we know about this treatment for kidney cancer. Kidney cancers are chemoresistant, radioresistant. That means there is no role of radiotherapy or chemotherapy in kidney cancer. That means surgery is the best treatment or the curative option. Now, whether to do a partial or a radical nephrectomy, like this, what you are seeing, this is a specimen of radical nephrectomy where the entire kidney has been removed along with fat fascia and lymph nodes around. Right? Now, when to do partial, when to do radical? If the tumor is less than 4 centimeter, partial. If the tumor is more than 4 to 7 centimeter, then in selected cases, we can do a partial nephrectomy. If the patient is having compromised kidney function, please remember, beta, if the kidney function is compromised, that means kidney ठीक से काम नहीं कर रही है, and there is a tumor, cancer in one kidney, then also we try to preserve as many nephrons as possible. Then we can go ahead with this nephron sparing surgery, partial nephrectomy. If the patient is having only one kidney, and in that kidney the patient has developed tumor, again we cannot remove the whole kidney, so we go ahead with a partial nephrectomy. Or if there is a cancer in both the kidneys, then also we have to do a partial nephrectomy on both the sides. Right? So please remember for 30th of July, beta, that this is there. These are the indications for partial nephrectomy, which we have to remember. Right. So in this particular question, beta, the tumor size is how much? 3 centimeters basically. So that means the answer will be partial nephrectomy. Agar beta isi question mein, if in this question the examiner would have written something like this, 7, and he has not mentioned that patient is having only one kidney or a compromised renal function or something like that, if the question would have been like this, then the answer would have changed to radical nephrectomy. Right? Fine. Very good, beta. Chaliye. So second last question. Before we move on to the second last question, we know that Powell said there are no secrets to success. It is the result of preparation, hard work and learning from failure. कभी भी घबराना नहीं है बेटा, है ना? अपनी मेहनत पे विश्वास रखना है, भरोसा रखना है अपने ऊपर और हिम्मत से मेहनत करते जाना है. Just 22 days to go बेटा. फोड़ेंगे, करके दिखाएंगे, क्योंकि हम वो दिन चाहते हैं जब हम अपने माँ बाप की आंखों में वो खुशी के आंसू देख सकें. We want to see the happy tears in our parents' eyes. So nobody can stop us in bringing happy tears in our parents' eyes. And we are going to do it for them. We are going to do it for ourselves. And we are going to do it for our respected teachers also. Right, beta? Yes. Now, another question, beta. 75 years old male is diagnosed with prostate cancer. Positron emission tomography (CT) shows FDG avid area of 2 into 3 centimeter confined within the prostate. No significant FDG uptake is seen elsewhere in the body. That means that prostate cancer is confined within the prostate. Which of the following will be the best management for this patient? Okay. So before we mark the answer, beta, Let us see what is the actual treatment story here. Suppose I say that this is a prostate gland. There are two things. If the cancer is confined within the prostate versus the cancer has gone beyond the prostate. So suppose on one side we imagine that cancer has gone beyond the prostate, say in the bones, because we know that prostate cancer spread to bones very commonly, lumbar vertebra through Betson's vertebral plexus of veins. And these bony metastases in prostate cancer are mainly osteoblastic. So beta, दो कहानियां हमारे सामने. In one story, if the cancer is confined within the prostate, if it is within the prostate, then we can easily remove the prostate gland and cure this patient. That means we can go ahead with radical prostatectomy, which can be done by open laparoscopy or robotic surgery. Like commonly nowadays, we are doing that robotic surgery, right? So these are the robotic equipments which can be used. Okay. Now, whether to do a radical prostatectomy or we can destroy it by external radiotherapy where we use iodine 125 and palladium 103, 105, right? Now, whether to do external radiotherapy or to do a radical prostatectomy, this can be the decision of the patient as well as the surgeon. Point is, prostate cancer is the commonest cancer in elderly males, and more than 2/3 of patients, more than 70% of patients suffer from prostate cancer. More than 70% of males after 80 years of age suffer from prostate cancer, right beta? And prostate cancer is a very slow growing cancer. If the patient's age is more than 70 years, where the life expectancy is just less than 10 years, and this prostate cancer is a very slow growing cancer, it may take a long time to grow. So whether we should do this radical prostatectomy or radiotherapy in this patient or not, there is a possibility that patient is going to live for 10 years and this prostate cancer may not grow enormously in 10 years. So why to give the morbidity of that radical prostatectomy or radiotherapy to this patient? So if the age of the patient is more than 70, that means life expectancy is less than 10 years and cancer is confined within the prostate, then we just do active surveillance. That means we just do a follow-up every 6 months. You can do a MRI. However, if the patient is less than 70 years of age, that means life expectancy is more than 10 years and cancer is confined within the prostate, then yes beta, then we can go ahead with that radical prostatectomy, which nowadays is commonly done by a robot. So that is a radical prostatectomy. Or we can even use radiotherapy. In radiotherapy, we can use that iodine 125, we can use palladium 103 as well, right? However, another story beta with where the cancer has gone beyond the prostate. अगर कैंसर प्रोस्टेट के बाहर चला गया है, हड्डी में फैल गया है, now we cannot remove the cancer completely from this patient. That means we cannot cure this prostate cancer. So we have to give a palliative treatment for this patient. And for palliative treatment, we do androgen ablation. क्या करते हैं बेटा? Androgen ablation करते हैं. और androgen ablation can be done either by medicines or by surgery. Medical androgen ablation कैसे कर सकते हैं बेटा? We can use LHRH agonist, जैसे गोसरेलिन वगैरह यूज कर सकते हैं. और सर्जरी में we can do a bilateral subcapsular orchidectomy. Bilateral subcapsular orchidectomy. We can do this, right? Please remember beta, bilateral orchidectomy is done for prostate cancer, for hormonal therapy, for androgen ablation in the palliative treatment of advanced prostatic cancer, right? Okay, fine. So यहाँ पे क्या आंसर होगा बेटा? What is the age of this patient? 75 years है ना? तो 75 years है, that means he is falling in this category. Cancer is confined within the prostate है बेटा, तो again he is falling in this category. So the answer will be active surveillance. इसको ध्यान रखना बेटा, बिल्कुल ध्यान रखना. Yes, गोसरलिन plus flutamide Right. Great. Chale. And now let's take a look at the last question, beta. Again, this is a hot question. I believe that without a question from breast cancer, it would be difficult for your examiners to make a paper, right? So, what is this, beta? Yes, very good, Divya. So this is a PUD orange, beta. We know that PUD orange is a hot question, right? PUD orange is a blockade of subdermal lymphatics by the cancer cells due to spread of cancer into the skin, which involve the superficial lymphatics, right? अब देखते beta what he's asking. PUD orange appearance involving 2/3 surface area of the breast is classified as which TNM staging in breast cancer? Right. So options are T4A, B, C, and D. Right. Okay. So majority of you are marking the answer is B. Okay. नहीं बेटा, एक बारी let us see the staging quickly, right? वैसे breast cancer की जो staging है ना इधर, तो इधर अगर अपन ध्यान से देखेंगे बेटा, तो classes में अपन ने कैसे किया हुआ इसको? Classes में हमने ऐसे याद किया था ना, 2 to 5, more than 5, any size, chest wall, skin, both, inflammatory. फिर से करते हैं बेटा, 2 to 5, more than 5, any size, chest wall, skin, both, inflammatory. And lymph node को कैसे याद किया था बेटा? Mobile, fixed, internal memory, axillary plus apical, axillary plus internal memory, and supraclavicular. है ना बेटा? N1, then N1, N2A, N2B, N3A, N3B, N3C, है ना? चलिए बेटा. So T4 staging को अगर देखें बेटा, तो T4 staging is A is chest wall, B is skin, C is both chest wall and skin, and D is inflammatory, right? अभी this PUD orange simply means involvement of the skin. So if it is involvement of the skin beta, that means it should be T4B. लेकिन please remember there is a catch here. If PUD orange is involving more than 1/3 surface area of the breast, then it is called inflammatory cancer. I repeat this beta. If PUD orange involves more than 1/3 surface area of the breast, then it is inflammatory cancer. And here the examiner has mentioned that it is involving 2/3 surface area of the breast. So what will be the answer beta? It will be T4D. So the correct answer is T4D, just because he is saying that it is involving more than 1/3 surface area of the breast. Right बेटा? Because ये PUD orange पे बहुत सारे question बनते हैं ना, तो हमसे कोई गलती ना हो जाए. We just want to make sure, because we are just 22 days away, and this is all about those 25 most important question. And I really wish you all the very best from the entire team of MIST. I am really thankful to all of you बेटा, जो आप इतना विश्वास, इतना फेथ रखते हो और हमें हिम्मत देते हो कि हम आपके सामने खड़े हो पाए. Thank you so very much. May God bless you. And before I just sign off, I would just like to remind you बेटा कि करना क्या है हमको, right? Just a small reminder बेटा, we want you to wear this stethoscope and that white coat very soon in Indian hospitals. So what we are supposed to do is we have to just keep this fire in our belly intact. इस आग को बुझने नहीं देना है. सिर्फ 22 दिन की बात रह गई बेटा, सिर्फ 22 दिन. पूरा डट कर मुकाबला करना है, डट कर मेहनत करनी है और पूरी दुनिया को अपना करिश्मा दिखा के रहना है. 22 दिन बेटा अगर ईमानदारी से, शिद्दत से, मेहनत से हमने रगड़ दिया ना, कोई नहीं हरा पाएगा. Just 22 days. Keep grinding, keep grinding, keep grinding very hard, because you have made lot of sacrifices in the last 5-6 years. which we all know about. There is a great contribution of your parents as well in the last 5-6 years to make this happen for you. And now it's the time that we have to prove our mettle. And believe my words better, if you just keep working very hard, consistently, honestly in these last 22 days, nobody on this earth has the power to stop you from coming out with flying colors, and you are going to do it. God bless you all. Wish you all the best. Thank you very much.